Today we'll pick up on chapter 6 and we'll start talking about some of the accessory structures of the integumentary system. So our first accessory is going to be the nails. And so when we look at the structure of the nails, the structure really is that the nail is a scale-like modification of the stratum corneum. The dorsal edges of the fingers and toes are really where we find these. And their function really is to help protect the distal tips of our digits, both of our fingers as well as our toes. They also help to assist in grasping objects. So obviously sometimes if you can't grab things with the actual base of your finger, oftentimes you'll end up using the nail part of your fingers to be able to grab things. When we look at the nail, we have the distal whitish free edge, and it's at this point there are no underlying capillaries. Then we get into the pinkish nail body, and when we get into that pinkish area, that's where we do start to see a lot of our capillaries, which again are these very small, just a couple blood cell thick blood vessels. We also have the nail root, and that nail root is going to be the part that's embedded into the skin. And these three structures, the free edge, the nail body, and the nail root, all constitute the nail plate. The nail bed then is the layer of living epidermis that's covered by the nail body. We also have a nail matrix, and the nail matrix is this actively growing part of the nail at the proximal end of the nail body. Remember your terminology, proximal and distal. Distal is going to be farther away from the point of origin. Proximal is going to be closer. We have the lunula, which is going to be the whitish semi-lunar area on the proximal end of the nail body. We do have nail folds, and these are the folds of the skin that help to come over and overlap the skin, overlap the nail. We also have the epinecium, which is the cuticle. And the epinecium is this narrow band of epidermis from the margin of the nail wall into the nail body. We also then have a hyponychium. And the hyponychium is the thickened stratum corneum over which the free nail edge projects. So this image basically gives us a good look at all of those components. And so you can kind of compare those previous couple slides to this image. Again, you can see the lunula, you can see the free edge, you can see this entire nail body. The epinecium or the cuticle all the way here to the back, the nail folds along the sides. You can also see the dermis and the hypodermis, the phalanx, the bone inside. So all of these structures you can kind of go ahead and take a look at and review. So just a few things regarding nails. So when we look at nails, we have different nail disorders. Some of them are going to be specific to the nail, and then oftentimes we'll find sometimes things that we find with the nails can actually lead us to notice other disorders throughout the body. So when we look at the nails, they're indicative of our overall health. Brittle nails tend to be prone to vertical splitting and the separation of the nail plate layers. Ingrown nails typically are where the edge of the nail actually digs into the skin. You'll often see this either with damage to the nail, or more commonly, people that dig or pick or cut their nails too short on the sides. Onychomycosis essentially is a fungal infection of the nails. Yellow nail syndrome occurs when the growth and thickening slows. We have spoon nails, where you see the outer surface of the nail is actually concave. And concave kind of has this, what we call a concavity, where it's got kind of an indent. Bowes lines indicate temporary interference with nail growth. And then we also have vertical ridging, which is usually common and usually harmless. So our next accessory then is the hair. Now hair is found almost everywhere on the body. And essentially what hair is, it's the keratinized cells that form a slender filament. And so what we see is that they grow from our hair follicles within our skin or our integument layers. There are three different types of hair. Lanugo hair is the fine, unpigmented, downy hair and typically occurs within the last trimester of development. We also have vellus hair. Vellus hair is the very fine hairs that we have throughout the body. This is the primary type of human hair and is what we find on the upper and the lower limbs of our bodies. We also have terminal hair. Now, terminal hair is coarser, it tends to be pigmented, and tends to be longer. We find these on the scalp, on the eyebrows, the eyelashes, as well as the beards of men. And then we see during puberty, our terminal hair actually starts to replace the vellus hair in a lot of our axillary and pubic regions. And again, if you remember axillary basically is referring to the arm, the upper part of the arm, so around the armpit. So if we look at the hair structure and some of the follicles, there are three zones along the length of a hair. We have the hair bulb, which is swelling at the base where the hair originates in the dermis, and it's going to surround the hair papillae, and this is composed of connective tissue. It's the only region of the hair that actually contains living epithelial cells. We also have the root, and the hair root is the zone of the hair from the bulb to the skin surface. And then we have the shaft, and the shaft is the portion of the hair that actually extends beyond the surface of the skin. When we look at the hair matrix then, again, these are additional hair components. The hair matrix is a structure at the base of the hair bulb. And what we see is these epithelial cells are actually dividing at this location. And as it does this, it helps to produce new cells. And as it continues to divide, it gradually pushes the additional hair matrix toward the surface of the skin. We have the medulla, which is the remnant of the matrix, and it's a very flexible, soft keratin structure. We have the cortex, which is the flattened cells that are closer to the outer surface of the hair, and the cortex typically is a relatively hard or harder structure. And then we have the hair cuticle, and the hair cuticle is a single cell layer that we find around the cortex. We also have a hair follicle. Now, when we look at the hair follicle is the oblique tube that surrounds the hair root. And what it does, it extends into the dermis and then also sometimes the subcutaneous layer. We see that it does have kind of an outer connective tissue root sheath, and this originates in the dermal layers. We also have an inner epithelial tissue root sheath, and it originates from the epidermis. And then we have the erector pili muscles. The erector pili muscles are thin ribbons of smooth muscle. Now, I know we haven't gotten into muscle tissue yet, but there are three different types of muscle. There is cardiac muscle, smooth muscle, and skeletal muscle. Smooth muscle is what we typically find in our organs aside from the heart that contains cardiac muscle. And so with smooth muscle, we typically don't have control over it. It's mostly involuntary. And so what these erector pili muscles do is they extend from the hair follicle to the dermal papillae. And as these muscles contract, they actually elevate the hair, and this is kind of what we typically know as goosebumps. So if we take a look here, you'll get a chance to see, just as we did with the nail, you get a chance to see essentially all of the structures and the components of the hair itself. From the shaft all the way down, you can see the root, where it goes all the way up to the skin surface. You can see the hair bulb, the hair papillae, matrix. Here's your hair follicle, cortex, medulla, cuticle. So again, you can see all of these structures here, and it gives you a chance to review these and again compare them to some of the parts that we just discussed on previous slides. And then we do have the microscopic image here that you can also take a look at. So what are some of the functions of hair? One, it's for protection, okay? We'll kind of go through this list here, but we have protection. We use hair for facial expressions. Obviously, it kind of gives us a layer, kind of a furry layer, if you will. So it does help in heat retention. We use it for sensory reception. Hair typically is very sensitive, especially if you ever notice with little insects. You know, if you ever notice a little ant that's crawling across your hair, you'll be able to feel that. Visual identification. So when we look at something and look at people, it helps to identify certain characteristics about them. And then it also helps us to disperse chemical signals such as pheromones. Some of the other characteristics that we see of hair is that we typically have different hair colors from individual to individual. So when we look at hair color and we look at hair, we go through the synthesis of melanin in the matrix that's adjacent to the hair papillae. Our hair typically is going to lighten with age as pigment production begins to decrease. So when we look at gray hair then, that actually results from the gradual reduction in the melanin in and around the hair. Whereas white hair typically occurs due to the complete stoppage of melanin production. Now, as we go through hair growth, there are three phases of the hair growth cycle. We have the anagen phase, the catagen phase, and the telogen phase. So with the anagen phase, this is active growth. Okay, so this is where we basically see active growth of the hair. Whereas when we look at the catagen phase, this is where we have a small brief regression period. And then we have the telogen phase, which essentially is a resting period for hair growth. Now, when we look at hair loss, on a given day for any individual, we normally lose anywhere from 10 to 100 hairs per day. Now, if we start losing too much hair, this is called thinning of the hair, and this is also called alopecia, and this typically is due to aging. Now, we can also have diffuse hair loss, which diffuse hair loss is not just the thinning of the hair. This is where we start to see hair that gets shed from all different parts of the scalp. Oftentimes we see this in women, and it can be the result of several different things. It can be due to hormonal changes, it can be due to iron deficiency, and it can also be due to drugs, both what we would consider some of the street kind, but also things that we may find in chemotherapy for cancers. We also look at male pattern baldness. And with male pattern baldness, we see the loss of the hair first from only the crown region of the scalp. And this is the result typically of some sort of genetic factor, but also can include some hormonal factors. We also have hirsutism, and this is excessive male pattern hairiness. So when you start growing hair or significant amounts of hair in different parts of your body, this is where we see this excessive hair patterns. So another one of our accessory components of the skin are going to be our exocrine glands of the skin. And our exocrine glands are a combination of sweat glands and sebaceous glands. Now, our sweat glands include two different types. We can have merocrine or eccrine glands, or we can have apocrine glands. So with merocrine or eccrine sweat glands, these are the most numerous and widely distributed throughout the body. Their structure really is just a simple coiled tubular gland, and what it does, it helps to discharge secretions onto the skin's surface. It does this through the process of exocytosis, and the secretion that it gives off is sweat. So our merocrine or our eccrine sweat glands are what we typically know as our regular sweat glands. So sweat is typically composed of about 99% water and 1% other chemicals. And these other chemicals can include electrolytes, metabolites, as well as waste production. And the major role that it has, or the major function it has, is the role that it plays in thermal regulation and regulation of body temperature. Our apocrine sweat glands are also coiled tubular glands. However, their discharge or their secretions go into the hair follicles that are located in the axillae, around the nipples, and in the pubic and the anal regions. Again, their secretions are also given off by exocytosis, and the secretions they give kind of give us this viscous or cloudy type secretion. We often will find proteins and different fats and lipids located within them. And this is the secretions that actually help to produce the odor when acted upon by bacteria. So anybody that has kind of that, I don't want to call it body odor, but typically just your body sense really is a response to the bacteria as it acts on some of these secretions and the proteins and the lipids within those secretions. And so we actually start producing these secretions during puberty. Now, our sebaceous glands are also known as holocrine glands. They actually produce an oily secretion called sebum. Now, this sebum acts as a lubricant for skin and hair. It's also bactericidal, so it does help to kill bacteria, and it discharges into the hair follicle. The secretions are stimulated by hormones, typically are androgens, and again are activated during puberty. We do have some other integumentary glands that are not quite as common or are located in very specific areas of the body. Some of those glands include the ceruminous glands. These are modified apocrine sweat glands, and instead of giving off sweat, since they're located in the external ear canal, we actually find that their secretion is cerumen, or what we call earwax. And so the function then of cerumen is to help trap the foreign material. It also helps to lubricate the acoustic meatus as well as the eardrum. Our other gland is the mammary gland. Now, our mammary glands are modified apocrine sweat glands, but we find these in the breast tissue of women. Its only function is in pregnant and lactating females, and it does produce the milk for the babies. So here's our kind of look at the skin and how we implement our glands into that skin tissue. You get a chance to see our American glands, and these obviously are going to release sweat up to the sweat pore and through the sweat duct onto the skin surface. Here you have your apocrine sweat gland, which allows us to add different fluids to the hair follicles. And again, our sebaceous glands, so on and so forth throughout the rest of the body there. So when we look at a clinical view then, we look at acne and different acne treatments. Now, acne is more of a plugged sebaceous gland, so those oily glands. We typically see this during puberty because we have an increase in this gland, and it can actually start to block the pores. Some of the treatments include benzoyl peroxide, salicylic acid, antibiotics, vitamin A-like compounds, systemic retinoids. But oftentimes, for some more milder cases, sometimes all it takes is just kind of spending a little time to really clean and wipe the face, both in the mornings as well as in the evenings, to try to clean it up and open up some of those pores if possible. Some of the downside to acne is it can actually lead to scarring if it's untreated and if you start to break some of the skin tissue. So how do we repair and regenerate different parts of the integumentary system? Well, obviously, if you have a small injury or cut the skin or open up the skin in some way, the cell has to be able to regenerate it. And one of the ways it does this is through regeneration. And so regeneration is the replacement of damaged or dead cells with the same cell type. And what this does is it restores the organ function, okay? Now, we also have a process known as fibrosis. Now, fibrosis is where we take a small gap of the skin and it actually fills in with scar tissue. And so instead of having this regenerated area of the same cell type, we can often have more collagen type fibers that are produced by our fibroblasts. And so in this case, the functional activities are not necessarily restored. So let's look at the stages of wound healing. So obviously we have an issue where we cut the skin. That means we've opened up blood vessels, and now we're starting to bleed into the wound. Our bodies then start to develop a blood clot, and we release leukocytes, which come in and clean the wound. And leukocytes are one of our types of white blood cells. The clot is actually a temporary barrier for pathogens so that things can't get directly into that tissue. As we start to continue through the process, we see blood vessels begin to regrow, and we start to see this granulation tissue that begins to form. And then we see vascular connective tissue initially forms within that wound. And then from here, once our blood vessels kind of regrow and begin to form and connect back to each other, we now get this epithelium that regenerates, and the connective fibrosis occurs within the tissue. So here you get a chance to see those 4 stages. So here you have your wound, the cut blood vessels that bleed into the wound. Here you have your blood clot that develops with our white blood cells and fibroblasts and everything coming in, trying to keep everything clean. Here we have our blood vessels that begin to regrow. And so you see this granulation tissue beginning to form. Our blood vessels are continuing to reach up to the surface of the skin. And now we get this epithelium that regenerates at our dermal and epidermal layers. And that basically seals off our skin, and we're left with kind of the scab of some of that fibrosis material that ends up getting just wiped off or moved off once that underlying skin tissue has completely healed. So another type of injury that we see with skin are burns. Now, burns are typically a major cause of accidental death. We have a lot of different types of burns as far as where we get them from. They can be caused by heat, they can be caused by radiation, chemicals, sunlight, as well as electricity. And the threat to life actually comes mostly, not necessarily from the burn itself, but it actually comes more from the fluid loss, the potential of infection, and then also the effects of some of the burned tissue, especially if it gets deeper into the skin layers. Now, we have several different types of burns that we're going to talk about. The first one is a first-degree burn, and it's going to only involve the epidermis. So this is going to be on the very surface of the skin. We'll typically see some slight redness and pain, and we can immerse the burned area in cool water. So, a burn of really hot water, not necessarily boiling water, but just hot water, a small sunburn, okay? Those are all different types of first-degree burns. A second-degree burn typically involves the epidermis, and sometimes we'll get into the dermis, or includes part of the dermis. In a second-degree burn, obviously we have a lot of pain, but we also see where the skin begins to blister. We also can see some light scarring. Typically, we would see this in a really bad sunburn or the possibility of being burned by some boiling water. All of these are the potential for second-degree burns. A third-degree burn is the next type and one of the significantly more serious types of burns. A third-degree burn is obviously going to involve the epidermis. It's going to involve the dermis, but then it also gets down into the subcutaneous layer. Third-degree burns certainly require hospitalization, but one of the big types of treatment that we're going to be treating for are, one, dehydration, but more importantly, trying to really prevent any infections from occurring at tissue that got down deep into the skin layers. Because of the process of dehydration and the tissue damage, the treatment also requires an additional caloric intake. We are typically going to see some severe scarring with third-degree burns, and may also require some type of debridement and skin graft. Now, debridement is basically the peeling away or the scraping off of a lot of the dead tissue. And the skin graft basically is putting on new, some skin from a different part of the body and allowing it to kind of grow and seal in around those burned areas. Now, those first three types of burns are the ones that most people are acquainted with. There are actually an additional three types. We go 4th degree, 5th degree, and 6th degree. You typically don't hear of 5th and 6th degree burns because, for the most part, if you get to that point, it almost ensures death at that point. But a 4th degree burn involves all layers of the skin, as well as causing damage to the bones, muscles, and tendons. So we've actually gotten deeper into the tissue. We're going down to really to the depths of whatever part of the body got burned. And obviously, because of this, we know 4th degree burns are very potentially life-threatening. Okay. Now, as we look at the burn severity can be measured by what we call the rule of nines. And the rule of nines helps us to estimate the surface area of those burned areas. Now, here are a few different types of burns that you can see. Here we have a 1st degree burn just on the surface of the fingers. Here you get your 2nd degree burn where we start to see some of that blistering in the skin tissue. A 3rd degree burn, we're starting to get a little bit deeper into the tissue, all the way down into the subcutaneous layers. And then here you start to see some of the 4th degree burns, where we've actually gotten all the way down into the tissue. We're starting to affect the tendons. You can see here certainly have affected some of the tendons in that wrist and in the hand. Now, going back to that, I do want to show you a real brief table of the rule of nines. So this image just kind of this website kind of gives us an idea of what the rule of nines are, especially in this case for adults. And what it does, you can see there, it basically divides the body basically into about 11 different areas and gives each of them essentially a 9% value. So essentially giving us 99% with the groin area being 1%. And so this is the rule of nines. So again, you can kind of use that for future reference. So what are some of the treatments for burns? Well, when we get into some of the more severe ones, obviously one of the big things is to manage fluid loss. We really want to make sure we do our best to try to prevent dehydration. We obviously want to relieve swelling. Too much swelling obviously is a bad thing. Certainly the more severe the burns are, the more pain we're going to have. And so we want to try to manage the pain as best as possible. We also want to try to remove dead tissue. There's no sense in the body trying to remove dead tissue on the surface and really, in a sense, working harder than it needs to when it's got other areas to work on. So our body is able to, or we are, I should say, we go in and we basically debride a lot of the dead stuff so that it gets off of the skin surface. One of the major things is when you get into 3rd and 4th degree burns is you really have to help work to control infections. Obviously, we've gotten deep into these skin layers, and so because of this, we need to make sure that we don't get any bacteria or foreign invaders getting into our bodies that way. And then obviously as a food source, we need to increase our caloric intake so that, again, we do have enough energy for the body to do its best to fight and repair some of the injured areas. So what happens as we get older? Well, there's a lot of skin changes that occur with aging. One, we're actually going to see a reduced number and activity of our stem cells that really are located again in that stratum basale. The skin repair process slows down, and this tends to start to form a lot more thinner skin. So thin skin is less likely to protect the body from trauma. We also see with thin skin, if you've ever seen or obviously with grandparents as they get older, if you've ever seen their skin, how it's a little bit more brittle and thinner, and it actually can tear relatively easy. So again, that's kind of one of those processes as your skin tissue ages. Kind of coinciding with that, you have fewer collagen fibers and also fewer elastic fibers, which causes the skin to lose some of its elasticity. We start to see different crease lines that begin to form, and these are what we know as wrinkles. We have fewer dendritic cells within skin tissue, which then means a decreased immune response within the immune system. Our hair follicles also produce thinner hair, or sometimes none at all. And this obviously leads to both hair thinning and baldness in some cases. When we look at aging according to UV radiation, obviously we know UV radiation is has a negative effect on skin tissue. And so UV actually damages the DNA in the epidermal cells. And by damaging some of the DNA in those cells, it actually accelerates the aging process. And this is a predominant factor in a lot of our skin cancers. So what is skin cancer? Well, it's the most common type of cancer that we experience. And it's typically on the head and neck, mainly because those are typically the most exposed areas as we go out into the world. Fair-skinned individuals typically are at the highest risk because they typically don't have as much melanin in order to help to absorb that UV radiation. So when we look at our skin tumors or skin cancers, most of them are benign and are not cancerous anyway, and they do not metastasize or spread. Some of the risk factors in skin cancer is really overexposure to UV radiation, but also frequent irritation of the skin. Now, this could be from UV radiation. It could also be from different chemicals that you get onto your skin. Now, there are some skin lotions that contain enzymes that can help to repair damaged DNA. And when we look at skin cancers, we typically are going to talk about the three major types. We have a basal cell carcinoma, a squamous cell carcinoma, and melanoma. So the basal cell carcinoma is the least malignant. It's the most common of the skin cancers that we talk about. It really affects the stratum basale, and so the stratum basale cells proliferate and slowly invade the dermis and the hypodermis. So it's actually going or growing deep into the tissue. And it's cured typically by surgical excision. So basically we just go in, we cut it out, make sure that we go deep enough, and that's essentially how you get rid of a basal cell carcinoma. But again, this is the least malignant of these. Our squamous cell carcinoma is the second most common type. It's going to involve keratinocytes of the stratum spinosum. We typically are going to see some sort of scaly reddened papule on the scalp, ears, lower lip, and the hands. It does have a tendency to be able to metastasize. However, with the squamous cell carcinoma, we do typically have good prognosis if it's treated by radiation therapy, or we can also go in and just remove it by surgical excision. Again, the same thing as before if we get deep enough to get it all. Our last one is melanoma. Now, melanoma is the cancer of melanocytes, and this is the most dangerous type of skin cancer, mainly because it has a very high metastasis rate and is also very resistant to chemotherapy. Treatment includes wide surgical excision that also is accompanied by immunotherapy. So this isn't simply just come down here and try to excise just right around the edge. We actually have to take out a bigger section in order to make sure that we get everything. Now, the key to survival with melanoma is the ABCD rule. And so you'll see here we have A, B, C, and D. We have asymmetry, which takes a look at the two sides of the pigmented area. And if we have asymmetry, they don't match. Okay. we want them to be, not necessarily want them to be, but if we have something or have a mark, we want it to mostly be uniform. And so if you compare sides here to here, you'll notice that those two sides do not match on the asymmetry component. We also will have border irregularity. And so here we see indentations throughout this tissue, okay? Same thing over here, indentations of this particular melanoma. We also take a look at the color, and the color is typically going to contain several colors. You know, if the color is uniform, usually that at least lends us to think a little bit more of a okay marking. But when we look at this, we have some red in here, we have some brown to black. Same thing over here, a little bit pinker, a little bit browner, a little bit more black through there. So again, we're really looking at multiple colors in this area. We also have to look at the diameter of the melanoma. And so if you see something that's larger than 6 millimeters in size, or what we typically would consider the size of a pencil eraser, we now have to consider the possibility of that marking being some sort of melanoma. And with that said, let's go ahead and make melanoma our attendance code word for the day, okay? So again, melanoma is our attendance code word. And so our last slide then for chapter 6, we take a look at another clinical view of Botox and wrinkles. So Botox basically is a treatment for wrinkles that we typically see caused by facial muscle expression, or I should say repeated facial muscle expression. Botox is actually the brand name or the trade name for the Clostridium botulinum toxin. So basically we're introducing a toxin into the skin tissue. And what it does is it blocks the nerve impulses to facial expression muscles. And so by doing this, we're actually decreasing or eliminating the wrinkles that are caused by facial muscle expression. The Botox is actually injected into a specific facial muscle and typically only gives us a temporary effect. The muscle will then eventually regain function, and eventually the procedure, if you want the effects, will eventually have to be repeated anyway. So that is the end of chapter 6. We will talk about our exam. I'll have a separate video for that as you prepare for it.